Welcome, guys. Can you hear me and see the PowerPoint moving?
Yeah.
Okay, perfect. So welcome. We have a couple of people in the room, and then the brush crew is out on a call, but they'll be here after a while. Tonight, we're talking about lab values and acid-base balance. And this topic, for those that aren't super familiar with lab values or acid-base, it might be a lot of information to try and deduct from, but I want you to know that this lecture is kind of a rough lecture in the sense that it doesn't go completely in depth on every lab value, and it's kind of an overall picture into patient care and kind of how our body works too. And then after we finish, we'll get a chance to practice some lab values and acid-base balance. Okay. So like I said, we're talking about acid-base and lab values, but why do I need to know these?
We need to know what's in our bodies.
We need to know what's in our bodies, right? Acid-base and lab values provide us with really clear and good insight as to the patient's overall health, and they help us to better treat them. Even in pre-hospital or doing interfacility transfers, it helps us to get a good patient care picture so that we know exactly what's going on with them. So today, our objectives are to determine what a normal set of lab values looks like, look at a few different lab tests, distinguish the difference in alkalosis and acidosis, determine the different types of metabolic disorders that take place, learn what types of lab values that may be critical to our practice, and then actually practice using these lab values. So some considerations looking at this lecture. Hospitals and different agencies determine their own normal set of lab values. So take these values tonight for what they are. Lab values are consistently changing from what normal ranges are as medicine progresses. And each hospital might use different units of measurement or determine that for glucose, for example, one hospital might be 80 to 100, the next one might be 60 to 120, and that's their normal. Also, lab values are subjective with different protocols, and providers may treat different than one provider. So I might treat different than Kyle does. Kyle's going to treat different than a doctor does. And then all of these lab values are average values that can be found through multiple different resources, and they're not definitive labs. As you may see, other agencies or ranges consider different values normal. So pre-hospital, we look at different labs on a sheet of paper usually, but we also are drawing blood, right? So when we draw blood, did you ever like learn a different tube to use first or last?
Red blood gives life.
Red blood gives life. So they tell us that a specific order that we draw labs is important, and it's because of one, what's in the tube, and then two, how those different tubes can work together or work against each other. So as we look at tube color, we have light blue, red or gold, green, lavender or pink, and gray. And we call this a rainbow, right? We're getting a rainbow set of labs. Whenever you go get your lab drawn though, or labs, whenever you go to the doctor, they might draw 3 or 4 gold tops, right? Or they might draw 2 or 3 green tops. Do we carry 2 or 3 or know exactly what we need? Not all the time, right? So we generally just draw the rainbow, and then if they need to draw more, they can. And they can also use one tube for multiple different tests, but they try and have at least a selection. So light blue They all, most of the time, have additives in them. Light blue has 3.2% sodium citrate, and it prevents the blood from clotting by binding calcium. And commonly it's used, we like to think is cardiac, so coag, and then they also run other cardiac enzymes off of the blue tube. Red or gold is a serum tube with or without clot activator or gel. And sorry, give me just a sec. Hey, Joe. Good, how are you? I'm in the middle of giving a lecture. Okay, sounds good. Bye. So if you draw the gold or red tube in the field, usually by the time you get to the hospital, you're going to actually see this coagged. So you're going to tilt it and it's going to be just like a clot. Green is sodium or lithium heparin with or without gel. So it prevents clotting by inhibiting thrombin and thromboplastin. And it's statin routine chemistry. And then lavender or pink has potassium in it and prevents clotting as well. This is used for hematology and blood bank. And then gray tubes are primarily used with sodium fluoride and potassium or potassium oxalate. And this is measuring glucose and blood alcohol, lactic acids.
This is all online as well.
This lecture will be online. Yep. So as we look at different lab values, we look at osmolarity. Okay, and osmolarity, its definition is it measures the amount of dissolved substance in 1 liter of water, 1 deciliter. So it's looking at the almost kind of the concentration, but the concentration is the amount of the substance present in a given volume of fluid. A cation is a positively charged ion. An anion is negatively charged, and osmosis is the diffusion of water across membranes. This is a quick review for these vocabulary words that we may not hear all the time, but have heard at some point in our life. Okay. So what type of lab values should we be looking at if we're looking at taking care of a patient? So we need to be looking at creat, carbon dioxide, chloride, sodium, potassium, bun, glucose, calcium, red blood cells, white blood cells, hemoglobin, hematocrit, platelets, total protein, INR, lactate, prothrombin time, partial thromboplastin time, all of the above. Okay, so this chart here lists out a few different panels that can be pulled. The first one is a basic metabolic panel. The second one is complete blood count, coag panel, liver function test, and then others. Okay, so that's how they're broke down. So if you go into the doctor and they're like, I want a CBC, they're looking at a complete blood count that looks at total calcium, ionized calcium, red blood cells, hemoglobin, hematocrit, white blood cells, platelets, total protein, albumin, and all of those are in one test. Okay, so they're usually done as a panel. We'll talk about these in depth. Okay. What is blood? It's the red sticky stuff. Is that what you're going to say? The red sticky stuff? Blood is made up of multiple different parts. And the first one, or the primary one, is plasma. It accounts for approximately 55% of our total blood volume. Then we have red blood cells, which account for about 45%. Platelets count for less than 1%. And then white blood cells are the same. And as you can see, the composition of blood on the right side of your screen, it's just red. We don't see any discoloration typically with it. And when we look at blood, it's one color, but it's actually comprised of multiple different moving parts that are carrying different types of enzymes, oxygen, and then fluid as well. Okay, so plasma carries nutrients, hormones, and proteins to our body, and also carries waste from our body. So this is kind of that school bus that likes to carry things to and from where they need to go. Plasma is made up of albumin, globulin, fibrinogen, and then other types of materials such as ions, nutrients, waste products, gases, and regulatory substances to keep our body at homeostasis. Taking some notes. Perfect. So albumin is 58% of plasma. It prevents fluids from leaking out into capillary space, creating edema. When do we commonly see edema?
CHF.
CHF. It's the primary one. Right. We get fluid retention. Okay, so it also transports hormones, vitamins, and drugs throughout the body. And normal levels of albumin are 3.5 to 5 grams per deciliter. This is kind of that plug, if you will. They keep everything in. Globulin looks like a glob. It's about 38% of the plasma. It has groups of proteins within it. It's made by the liver, and it's utilized in liver function, blood clotting, and fighting infection. What else fights infection?
White blood cells.
White blood cells. Muscles. Your heart. It's what's inside that matters. So you can see on the globulin on the outside or the exterior, looks pretty messy. And then even on the inside, there's multiple different colors and parts and pieces that make up those groups of proteins. Okay. Fibrinogen, also called factor 1, accounts for approximately 4% of the plasma. It's also made in the liver, and it's converted by thrombin to make fibrin, which makes blood clots to stop bleeding with the help of blood platelets. Normal levels of fibrinogen is around 2 to 4 grams per deciliter. What's more medication that we carry that might mess with fibrinogen? Yeah, aspirin. How does aspirin work?
The antiplatelet aggregate.
It's thromboxane V2. Converts factor 1 to factor 2. Which activates fibrin.
So it stops the conversion of factor 1 to factor 2. Okay. So going back, a complete blood count, or a CBC, looks at red blood cells, white blood cells, hemoglobin, hematocrit, total calcium, ionized calcium, platelets, total protein, and albumin. Our goal here is just to understand the concepts and somewhat the values of each of these different levels. Whenever you look at a complete blood count, you'll probably see this graph more than once within your career. So they set graphs up like this so that it's easy for providers. They use it in labs. And we're going to talk about each of these as well. Red blood cells. Red blood cells are those plates, right? They look like spheres. They're a little bit flat. They're made in the bone marrow. They contain the protein and hemoglobin. What is hemoglobin?
The protein that binds to oxygen, carries it from your lungs to your body, and CO2 back from your body to your lungs.
Okay, perfect. So by testing the levels of the red blood cells, it may lead us to a diagnosis of anemia, sickle cell, iron deficiency, and I can't ever pronounce this. Hemolytic. I look at it and it sounds and looks weird and my brain doesn't work with it. Dehydration, malnutrition, leukemia, etc. So red blood cells gives us kind of an idea of, is the body producing red blood cells? Are they not producing enough? And then is it actually able to carry the adequate amount of oxygen to the rest of the body? Like Justin said, it carries oxygen through hemoglobin and carries carbon dioxide to the lungs to be expelled. So again, it's one of those transporters that is taking good things and bad things away. They live about 120 days and then they die. There's approximately 5 million per microliter of blood. So whenever you look at red blood cell count, you're looking at that number, approximately 5 million. Hemoglobin is the protein in the red blood cells that carry oxygen from the lungs to the body tissues and carbon dioxide to the lungs that can be expelled through the lungs through cellular respiration. Low hemoglobin, though, leads to hypoxia as a result of that decreased transportation for the oxygen to be carried to the body tissues. So if we don't have enough hemoglobin, are we carrying enough oxygen? Probably not, right? And this level is approximately 15 grams per deciliter. And again, hemoglobin is in those red blood cells. White blood cells, on the other hand, are also called leukocytes. They fight viruses, bacteria, and other foreign bodies. They're made in the bone marrow as well and live 1 to 3 days. Marrow is constantly making them, just like the red blood cells. But instead of, you have a red blood cell, right? And it's one name, you have multiple different types of white blood cells, and they all treat different things. So monocytes break down bacteria that we might have within our body. Eosinophils kill parasites and cancer cells and help with allergic response. So if somebody is having an allergic reaction, it's going to try and fight off whatever allergen that they have. Basophils secrete histamines in allergic reactions. Lymphocytes fight the bacteria, viruses, and other invaders. They're kind of the all-encompassing. And then neutrophils bill and digest bacteria and fungi. There's an abundance of these, and they're the first line of defense. These are your first line army guys that are going to fight, and then the next wave comes in and they step in, right? And then the next one steps in. So white blood cells are approximately 4,500 to 11,000 grams per deciliter. If you have an increased white blood cell count, what's commonly taking place?
Infection.
Could be an infection,
Infection.
something within the body that shouldn't be there, right? The body recognizes the need to try and fight off whatever it is that's within the body. So it's going to generate white blood cells so that it can go fight off that bacteria or that virus or whatever it is within the person's body. So White blood cell count, if you know kind of a range, and then you get a white blood cell count back that's 23,000, you know that they're trying to fight off some type of infection or something else is going on. Okay. Hematocrit. So hematocrit is that approximate 45%. It's the percentage of the blood that has formed red blood cells within the plasma. So if you're looking at this graph here, your blood sample, the top portion, the yellow, is plasma. The bottom portion is that hematocrit, and it's approximately, this chart says 42%. I've always heard 45%. So take that for what it is. Again, different ranges for different people. So hematocrit is this bottom part that has that percentage of the blood that's formed those red blood cells within the plasma. If somebody has a hematocrit of 40, then they have 40 milliliters of red blood cells in 100 milliliters of blood. Does that make sense?
Yeah.
So this is what it kind of looks like whenever it's spun down.
Mhm.
You heard that term before, you're spinning down the blood. So when they spin it down, they do take a look at, well, is how much of the tube is actually this hematocrit? Is it really low? Is it approximately 42 to 45%? Or is there a lot of it? Okay. Platelets or thrombocytes are small colorless cell fragments in our body that form clots and stop or prevent bleeding. Platelets are made in our bone marrow, the sponge-like tissue inside our bones, and bone marrow contains stem cells that develop into red blood cells, white blood cells, and platelets. So going back, platelets are also called thrombocytes, right? They're very, very tiny. They help in the formation of clots to stop bleeding, and they're made in that bone marrow again. They contain stem cells, and the stem cells develop into red blood cells, white blood cells, and platelets. And right now there's a lot of studies and other treatments for different types of disease processes that you're actually getting stem cell therapy, or stem cell research is being done to be able to treat whatever it is that's going on. Platelets are approximately 150 to 400,000 per cubic milliliter. And that's how it's measured whenever you're looking at lab values. Total protein. So total protein consists of albumin and immunoglobulins. Albumin is made in the liver, and it makes up 60% of that total protein. Like I said, it prevents that fluid from leaking out of the blood vessels and transports hormones, vitamins, drugs, right? So the albumin is almost like that plug that's keeping everything in. Globulins are made from the liver and immune system and make up the other 40% fighting infection and transporting nutrients. So protein is really important. That's why we're checking protein pretty frequently. We want to know what that transport method is, right? We want to know, is the body able to actually transport these things to where it needs to go? And it's approximately 6 to 8 grams per deciliter. All of my slideshows that I've ever made have little clips. Does anybody have any questions so far? Am I going too fast?
I just go over the lectures again.
Okay.
When the kids are in bed. I'm just like,
Perfect. Total calcium. This looks like TOT, CA. It might look a little bit different. Calcium is usually wrote on lab values as CA or CA plus, but this one's going to look different with that TOT, so that you know, or T, just T, so that you know that this is total calcium. It's different than regular calcium. It's approximately 8.5 to 10.2 milligrams per deciliter, and it's super essential in the body because it's essential electrolyte, right? And 45% is free and dispersed in body fluids. And again, just like what we've talked about previously, this is broken down even further into smaller parts, right? 43% is bound to proteins so that it can travel. And then 10% is bound, that's supposed to say bound, to molecules like citrate, lactate, phosphate, tates, all those tates. And then it's dispersed in those body fluids, binding to these types of things so that it can carry those. And we can have hypercalcemia or hypercalcemic patients, which is greater than that 10.2 milligrams per deciliter. Obviously, if you're getting into the 15, 20-ish range, that's very hypercalcemic. I would say 10.3 is probably not considered hypercalcemic on its own. Causes of hypercalcemia include hyperparathyroidism, tuberculosis, thiazide diuretics, and then kidney transplants. Some common symptoms that you'll see with hypercalcemia include increased thirst and urination, abdominal pain, bone pain, nausea, weakness, and fatigue. What are some other diseases that have those similar symptoms? Diabetes, yeah. You have that increased thirst and urination. What is that called?
Polyuria.
Okay. Polyuria is urination.
That's what it is.
Polydipsia is thirst, and polyuria is urination. Abdominal pain, bone pain, nausea, weakness, and fatigue. Whenever you guys were growing up, did you ever have that like growing pains, right? You literally feel it in your bones. It's like that, except worse. That's what it's described like from patients. And then weakness and fatigue for hypercalcemia. On the opposite end, hypocalcemia is going to be less than 8.5 grams per deciliter. And its causes are decreased calcium and vitamin D, low albumin, alcoholism, liver disease, pancreatitis, renal failure. Okay, so hypocalcemia is something that we can actually recognize, and it's pretty crazy. And I think right after I finished paramedic school, this was like almost an assessment tool for me sometimes, but it's very, very good. Symptoms include anxiety, confusion, delirium, hyperactive reflexes, prolonged QT intervals for those ALS providers, narrow QRS complexes, and possible U wave in your 12 lead EKGs. So again, anxiety, confusion, delirium, hyperactive reflexes. Those are pretty encompassing without putting them on a 4 lead or 12 lead, having a paramedic to be able to diagnose what the rhythm is, or a physician. So hypocalcemia, you can actually recognize through Trousseau's sign and yes, Chavinsky's Chopstick sign. So Trousseau's is an induction of carpal pedal spasms. So if you're taking a blood pressure and you are inflating your blood pressure cuff, it's pretty crazy. You'll start to see that bending of the hand and the clamping of the fingers, the carpal pedal spasms, and they won't be able to relax that.
What if that happens without the cuff?
Like what?
What if your hand flex or
Is it both or just one?
both?
Like anxiety? Because this happens with anxiety driven. Like hypocapnia, you're breathing too fast, you're breathing off too much carbon dioxide. So whenever you breathe off too much carbon dioxide, you start having carpal pedal spasms and it hurts really bad and you can't get your hands to stop.
Usually when I'm doing like in the middle of something.
Yeah. So
Like
just focus
today
on your
was
breathing.
Cutting onions. My whole, everything just went like that. So just looking at that, I was like, hey,
No, this is like induced. So we're inducing this sign.
okay,
Child sex sign is different though. It's tapping of the face, and we'll tap their face, and you get contraction of those facial muscles whenever you tap them. You might get twitching of the lip, spasms as well. So you'll like seriously tap them, and they're like, but it's not like if you tell somebody to focus on me and you tap their face, they should be able to pay attention to you without doing that or flinching, right? It kind of seems like they're flinching, but if you do it and they're like not able to control it, you might have a positive sign. Treatment for ALS providers or in hospital might be calcium gluconate. It's less potent than calcium chloride, and we're giving it slow. So if we give it in a bolus, it can lead to complications such as hypotension, syncope, or arrhythmias. And if it's severe enough, our protocols for pre-arrest would be calcium chloride, 3 milligrams per kilogram, IV IO slow push. And then we're remembering our rule of tens. So giving calcium chloride, we call it the rule of tens because we have a 10 milliliter of a 10% solution, slow IV push over 10 minutes. The usual adult dose is 10 to 20 milliliters IV over 10 minutes, and we may repeat every 10 minutes. Okay. I know that's a lot, but rule of tens, 10 milliliters of a 10% solution, slow IV push over 10 minutes. And we would probably be looking at both of these signs. If we started taking somebody's blood pressure and they started tensing up, I'm going to be thinking, okay, that shouldn't happen, right? So I might be starting to perform this Fosges sign. This dude's name. They couldn't just be like Smith sign, right? Like something easy.
no, because obviously it was his last name, first name. came up with.
Right.
Selfish.
What was his first name?
Right?
Fred.
Fred
Fine.
sign.
You know what I'm saying? Like all these I can't.
Fred sign.
I'm terrible with names. So we might be performing these kind of assessment tools and starting to kind of clue in, okay, we need to put them on a 4 lead. We need to do a 12 lead. And then we're going to be looking for those prolonged QT intervals, narrow QRS complex, and possible U waves. Encompassed with the anxiety, confusion, delirium, and hyperactive reflexes. You might tap their knee to see if you can get some type of response from any type of their reflexes. And if they're hyperactive, you're kind of going down this guy is super sick. We might be using calcium chloride and doing that 10 of 10 for 10. Ionized calcium, again, different than total calcium. It's approximately 4.5 to 5.6 milligrams per deciliter. And it's measuring the amount of calcium in free form in that bodily fluid. How much did I say was in free form?
45%.
About 45%. So it's measuring that specific amount in free form in the body fluids. And it helps to assess renal function. I own a Mac, so everything is auto-corrected. Retail function. This is renal function. So it helps to assess renal function, acid-base derangements, and trauma. Okay, still doing good?
Yeah.
All right, done with that one. Now we're on basic metabolic panel. A basic metabolic panel is looking at sodium, chloride, blood urea, nitrogen or BUN, potassium, bicarb, creat, and glucose. And again, here's another one of those charts here that you're going to see pretty frequently. I love this one on this slide. It's so basic. Let me go back.
No, I got it.
So sodium. Sodium is 135 to 145 milliequivalents per liter. Sodium is a primary extracellular cation that helps nerves and muscles interact. What do I mean by that?
Say the sentence again.
It's a primary extracellular cation that helps nerves and muscles interact.
So it's a negatively charged ion that stays in your like synaptic, no, in the cellular interstitial space. Positive ion. It stays in the cellular interstitial space. Consists with
Yes.
body function.
Do you have a better answer?
Probably.
I just like to think of sodium as the, you have to know it's the extracellular cation that hangs out outside of the cells, but I like to think of it as the 1/2 of what you need for action potential. So sodium, potassium, are the two stars you need for everything that the body does.
Yes. Including muscle contraction. And our heart is a big muscle, but also the rest of our body, we want to be able to function without our muscles. So that's why sodium is very important in our entire body. Hyponatremia is the low sodium, right? Hyponatremia is low sodium. And we see hyponatremia in CHF, renal failure, liver disease, heavy exercise, dehydration. And then this is also pretty interesting too, syndrome of inappropriate antidiuretic hormone. For those that aren't familiar with that, I would suggest looking it up because it's pretty cool in how antidiuretics work and kidney function within our body. And we could actually have a whole lecture about it. It's really cool. And it goes in conjunction with like angiotensin aldosterone system, loop diuretics.
You know what diabetes insipidus is? It's the exact opposite of that.
So I said that normal is 135 to 145. However, if less than 125 milliequivalents per liter, it can cause behavioral problems, muscle twitching, and cardiac arrhythmias. So it's pretty narrow window, right? You have literally 10 milliequivalents per liter that you're looking at. And if you get outside of that range, you're really going to start experiencing some pretty drastic symptoms, right? It's not like glucose where people get pretty out of range, right? We see patients that live in the 300-400s and they're fine with that. That's their body. They can do what they want, but they're not going to see some immediate drastic changes like you would with sodium. Patients that are low definitely need to go to the hospital. And primarily they're going to be admitted. And this is something that's going to take over a period of time. We can't correct it right away, again, because we're going all the way into the cells. It's not a quick fix. And they're going to receive 2%, 3%, 5%, or 23% sodium chloride, which is hypertonic solutions. What are we carrying on the ambulance? 0.9%, right? And 0.9 is considered isotonic, right? So 2, 3, 5, 7, even 23%, that's a lot of salt, right? So they're going to be receiving these hypertonic solutions over a period of time while also receiving diuretics as well. Need me to go back?
Just real quick. You're good.
So on the opposite end of that spectrum, greater than 145 is hypernatremia. greater than 145. Increased sodium can cause fluid retention. Again, we talked about fluid retention earlier a little bit. Primarily, we see that with CHF patients. And it can be caused by dehydration, poorly controlled diabetes, large burns, and can lead to arrhythmias with cardiac activity, kidney failure, further dehydration. Okay, so increased sodium, again, like decreased sodium, is potentially fatal if not treated appropriately. Large burns is one of the big things that we're concerned about, especially in critical care ICU picture. We're looking at large burns as fluid shifting, right? Fluid's going to start shifting. What also shifts with it? Everything else, right? All of these electrolytes that are in our cells and our body is going to start shifting where it shouldn't be, and it can lead to death. So treatment for this is going to be 5% glucose or 0.45% sodium chloride, which is a hypotonic solution. When we think of hypo, or isotonic solutions, can you tell me what the difference is in between all three of them and what they do? Hypo, isotonic solutions.
So hypo has less salt, iso has the same amount of salt content as your body does. Hyper has more salt than the body.
So what's happening?
Oh, so the water follows the salt. So if you have a hypertonic solution, you'll be pulling water out of your cellular membranes into the interstitial space and maybe into the vascular.
Did you say hypo?
Hyper.
There you go. I don't think salt. It's just about the tonicity, so it could be anything. It doesn't have to be the salt. that's in the solution.
So if I give you a hypertonic saline, I give you 5% saline, what's happening?
What's happening is
What's going in where?
the water is being pulled out of my cells into the vasculature.
Okay, and then hypo,
Hypo would be the water going out of your vasculature into the interstitial space into your cells.
perfect. So we talk about gradients, right? And you talk about gradients in A&P. We've heard those terms before. It goes from high gradient to low gradient, right? So that's exactly what's happening here. We're going from high gradient to low gradient to try and even out. If I gave you a cup full of water and a cup not full of water, I want to try and even them out, right? So I need to move some water from this cup into the other one.
Are you gonna say cup into the other cup?
Yes, I was.
Cup not full of water.
Cup not full of, the cup not full of water into the other cup that's full of water. So
Cup full of full cups.
we just talked about sodium and we're going to talk about potassium really quick. Just like sodium, potassium is just as important, right? It can cause death. And it's pretty severe as far as we have a narrow window with potassium and it's 3.5 to 5 milliequivalents per liter. Just like sodium, it's a primary intracellular cation that helps cell excitability, resting membrane potential, myocardial contractility, etc. So again, this is helping with muscle contraction, right? So we hear these terms: excitability, resting membrane potential, myocardial contractility. In what aspect? These three terms. Contraction of what?
Your muscles, all muscles.
Primarily-
skeletal and cardiac.
Um,
And smooth probably.
huh?
And smooth probably.
It's a muscle.
Yeah.
So hyperkalemia is greater than 5. Some causes are tissue breakdown, metabolic acidosis, acute renal failure, and we can see symptoms such as cramps, nausea, hypotension, bradycardia, and numbness. Those are pretty drastic symptoms, right? If we get a little bit of cramping, that's all right. But whenever we start having hypotension, bradycardia, and numbness, that's a pretty progressed hypernatremia, right? Or excuse me, hyperkalemia, correct?
Hmm.
For ALS providers, we're going to see EKG changes such as tall peaked T waves. And we look at those on every lead. We might do a 12 lead and have one lead such as V1 or V2 that we have tall peaked T waves, and they're going to be tall. However, especially with hyperkalemia, we're going to see those peak T waves across our entire 12 lead. So treatment for hyperkalemia can be mild, moderate, and severe, and it depends on the levels and symptoms as well. So mild treatment would be a non-potassium sparing diuretic. Diuretics do what? They make you pee. So furosemide or Lasix, which would be 40 to 80 milligrams IV. And then resins such as Kxalate, 15 to 30 grams to 100 milliliters of 20% sorbitol, either orally or by retention enema. Moderate treatment is going to be glucose and insulin. It's going to be 50 milliliters of D50 plus 10 units of regular insulin over 15 to 30 minutes. Sodium bicarb, 50 milliequivalents IV over 5 minutes. And then albuterol, 10 to 20 milligrams nebulized over 15 minutes. Well, that's weird.
Mm-hmm.
What's happening?
Their lungs probably are acting up.
With the, that's why we're giving the albuterol.
Or to help the, because since it's steroid.
It's a
Not a
not a
steroid.
steroid. What is it, Justin?
I can't remember.
Yes, you can.
Put me on the spot like that.
You can give it. You got this.
Let me kill myself.
That's not a steroid.
Adrian, what is albuterol?
As in what?
Medication class. You take it.
Shut up.
Close, it's not
I do
paranormal.
too, and that's.
Give me a second, give me a second.
What can I say?
It's beta 2 inhibitor.
You're right there.
Sympathomimetic.
That a boy.
Okay. So glucose and insulin. Why are we giving glucose and insulin for hyperkalemia? Kyle?
The insulin is going to allow the door open for the cell to let glucose in, and because of the shift of glucose and insulin in the cell, it will also facilitate potassium moving back into the cell.
And then bicarb?
Bicarb is going to change the pH balance of the body, and as the body becomes more alkaline, it also facilitates moving potassium back into the cell as the body moves hydrogen ions to compensate for the electrical gradient.
And then albuterol.
Same thing. As the
So really, we're
glucose
working
and
it from multiple different angles, right? And we want the, yes.
I saw the screen right before.
So severe treatment is going to be all of the above. And then also that calcium chloride, we're going to be giving 50 to 1,000 milligrams IV over 2 to 5 minutes to reduce the effects of the potassium and lowers the risk of ventricular fibrillation. So this is actually in our protocols for severe hyperkalemia. We can give calcium chloride 3 milligrams per kilo IV IO, slow IV push, and we're remembering those rule of 10s, 10 milliliters of a 10% solution, slow IV push over 10 minutes. And then usual adult dose is 10 to 20 over 10 minutes, and we can repeat it every 10 minutes. When would we as a provider in the field decide, hey, I got to do something because I'm 99.9% sure this guy has hyperkalemia. When would you decide
To do something about
to
it?
give Kals?
If I was starting to see like sine waves on the EKG.
Yeah, I would do it if I saw EKG changes for sure.
Just gotta be careful with the tall peak T waves because there's other things that could show
Right.
stuff like that.
Hypokalemia is less than 3.5 milliequivalents per liter. Causes again are cellular shifts such as insulin or hypothermia, GI or renal losses, Lasix, and then may have malaise, weakness, poor dietary intake, and then their EKG is going to show depressed and inverted or flattened T waves. Complete opposite, right? We saw the tall peak T waves with hyperkalemia. We're going to see the opposite with that. Short, flat, and maybe even non-existent T waves. Our treatment, we can't do anything in the field here, but potassium is definitely going to be the treatment for them. They're going to get a drip or potentially oral supplements depending on how low the potassium is. And potassium is going to change about every 0.6 milliequivalents per liter for every 1 change in pH. That'll make sense whenever we start talking about acid base and pH balances. Okay. So your potassium's changing when your pH changes, your sodium's changing, your whole body's just screaming on the inside because it's all messed up, and these people are really sick, and they got to go to the ICU. We can't do much for this, right? We can't. I would love to be able to run labs in the field and be able to treat these patients, but we can't necessarily do that. There are signs and symptoms that we can look for, but we're not going to know a definitive number. Yes.
So what can we do as EMS for a hypokalemia?
For hypokalemia is really going to be supportive treatment and transporting.
Diesel therapy.
They're
Because really what they
these
need
ones
for-
are going to have less likelihood of being fatal than your hyperkalemia patients. But whenever you start talking about polarization and repolarization and depolarization, you're going to have probably some delays, and it can be absolutely fatal over time, but you're going to see less symptoms than what you're going to see with hyperkalemia. Good question. Chloride is 96 to 106, a really easy way to remember this lab value. Chloride, hot tub, right? You put chlorine in your hot tub. A normal temperature of a hot tub is 96 to 106.
How many?
Right?
I'd be so mad if I got in a hot tub that was 96 degrees.
That's why I get in the 106 one.
There you go.
My
So-
hot tub's usually at 96 degrees. It's my daughter's personal pool.
I'm a very simple-minded person, so lab values, yeah, thank you. Lab values, I have to really try and simplify so that I can remember them easier. But hot tub temp, 96 to 106. Again, this is similar to the labs we've talked about previously. It's also an extracellular anion. It maintains osmotic pressure and helps the stomach produce hydrochloric acid. It's important in understanding how the kidneys concentrate urine, and hypochloremia may show impending renal dysfunction. So chloride is one test that we can look at renal function, but we also will talk about others here in just a minute. It tends to shift with your sodium as well. So as you see decrease in sodium, you're also going to see a decrease in chloride as well. It's a very narrow window, right? 96 to 106. All right, so moving away a little bit, venous carbon dioxide, ABG, or an arterial blood gas, they're drawing up your carbon dioxide that's in your arteries. This is a venous carbon dioxide, which is measuring the same thing at different, not intervals, but it's not going to be going into your body, it's coming out of your body, but you're still able to see what their total carbon dioxide is, and it's looking at the post-cellular metabolism. So we want to understand acid-base balance, and venous carbon dioxide is 22 to 26. And then it's kind of like our venous bicarb level a little bit. Normal bicarb is 22 to 26. So you can correlate the two. Venous carbon dioxide, 22 to 26. Does anybody have any questions so far? I'm not going too fast. Where's your partner?
Doing the reports.
Blood urea nitrogen, or BUN, helps to provide an overall picture of renal clearance. What do I mean by renal clearance? Renal clearance.
Is it how well your kidneys are filtering out the impurities and toxins and whatnot from your plasma?
That's exactly what it is.
Oh, good.
Yeah. You're just.
Oh, I thought you were raising your hand for a question.
No, he just speaks.
I should have known.
So looking at renal clearance, you guys are going to hear that throughout your guys' careers, even in paramedic school. Looking at renal clearance, it's a product of protein catabolism, which is the breakdown of complex molecules to simpler ones. Okay, and it tends to increase with age as renal function decreases. We know that as we get older, our kidneys just aren't functioning as they were whenever we were 20 years old. So we're looking at our total renal clearance. This is 8 to 23 milligrams per deciliter. I remember this one for FPC, and now even there's 8 buns in a hamburger package. So that was my starting point.
And then you pay $23 now for a good cheeseburger.
Sure.
Not bad.
Yeah.
All right, here we go.
I mean, this is seriously how my mind works. Like even looking at labs, I'm like, bun. There's 8 buns. Okay.
That's the best way to do it. If you can come up with little memory devices for this kind of stuff.
I mean,
it'll save you.
I understand what it's doing, right?
Yeah.
But I have to remember each of these lab values. So I'm like, I gotta seriously simplify this so that at 2 o'clock in the morning, I'm like remembering what the level is.
So as we increase with age, our BUN will increase as our renal function decreases.
Yes.
Okay, so what if it's flipped over? What if we have a lower BUN? Does that mean we have a higher renal function?
Yes.
Or you potentially have a problem with the system that ends up producing nitrogen. Because all that you're looking for in your BUN is the amount of urea nitrogen in the blood. So think of it like that. Like if we have a lot of it in the blood, then the kidneys are sucking what they're doing. We have less in the blood, and the kidneys are doing what they're doing. Or there's a problem with creating.
Creatinine, or CR, is 0.7 to 1.4. If you take 0.7, multiply it by 2, you get 1.4. That gives you your range. It helps to provide a picture of renal clearance again, and it's produced at a steady rate. If it's abnormal, it doesn't point to a specific disease, but it tells us how our kidneys are functioning. High levels can result in permanent kidney damage, as we know. We don't want kidney damage, right? We only have 2 of them, and they're pretty important. Once our kidneys go, then our liver goes, our heart goes, we just die. So we need kidneys. I mean, people go on dialysis, but if we didn't have dialysis, it'd be really bad. So going back to our BUN, there is a BUN to creat ratio. So you have your blood urea nitrogen on one side, creatinine on the other, equals normal, right? Normal is 12 to 20. And then the optimum is 15. So your creat ratio would be 20-1. Does that make sense? So if you're looking at up here, they are using 12-20 here instead of 8-23. And this one's 0.7 to 1.4. So they're looking at bun to creat ratio to see again what your renal clearance is. And a low renal clearance is acute tubular necrosis, low protein intake, starvation, or severe liver disease. If you have a high bun to creat ratio, you have pre-renal uremia, high protein intake, or after a GI bleed. And then if you have a high with raised creat, you have post-renal obstruction, pre-renal uremia with renal disease. So these are kind of different factors whenever they're looking at your bun and your creat. They take both of those and then they're able to more further diagnose what's actually going on with you as far as your renal system takes place. So creat is, again, a chemical waste molecule that's generated from muscle metabolism. It comes from muscles. Creat is transported through the bloodstream to the kidneys, and then the kidneys filter out most of the creat and dispose of it through urine. Okay, so if we have a high creat, are we able to dispose of it? You have a high creat. Your body's not getting rid of it, right?
Yeah.
But is it still producing it? Absolutely. So again, going back to, if you have raised creat, your bun might be normal-ish, you're just not able to filter that out. Or you might have a high creat, high bun, and you know that the kidneys aren't able to filter like they should. Glucose, I'm going to kind of skip over this one, 70 to 110. It's the amount of glucose that's circulating in our blood. We're pretty familiar with glucose, right? This we can test for using a finger stick. Finally, we can test for something. Coag panels. Coag panels are used to determine normal or abnormal clotting times and factors. Why do I need to know this? Or what?
Blood thinners.
Yeah, blood thinners, right? People that are taking blood thinners, what do they typically have to do frequently?
Get their blood tested.
Yeah, they go in and get their blood tested, right? I want to see, is this warfarin that I'm on too much? Is it the right amount? Is it not enough, right? Why might patients be taking a blood thinner?
For AFib, previous strokes.
Previous heart attacks, PEs, DVTs, right? All of these things that can cause clots. And earlier we talked a little bit about fibrinogen, right? And that's working differently than what we're about to talk about. Fibrinogen is helping to make the clot, but we're looking at prothrombin, prothromboplastin time, and INR. So prothrombin time, or PT, usually whenever you see these on a panel, it's going to be PT, PTT, INR. And it's literally measuring in seconds. Okay, so prothrombin time is an extrinsic pathway. We're looking at external trauma. You can have blood escaping or hypovolemia. So if we have a lot of blood loss, what do we need to give them at the hospital? Blood, right? Because we need them to be able to clot. And if they're losing all of that blood, we're filling them with saline, 0.9% saline. Then what's happening?
Thin the blood further, they just bleed more.
We're going to thin the blood further. They're not going to be able to clot appropriately. And what else is carried in our blood?
Oxygen.
Oxygen through our hemoglobin. Absolutely. So this is measured 10 to 13 seconds. That's a pretty normal time. Our partial thromboplastin time, or PTT, is an intrinsic pathway. It's internal trauma, platelets, endothelium, chemicals, collagen, and then all of these different factors. Okay, so this one's 25 to 40 seconds. So tests of the clotting pathway. On the right side, we have our intrinsic or extrinsic We have a PTT and PT-INR with all of these different factors. The PTT is used to evaluate coagulation factors here, prothrombin and fibrinogen, which is where we get the prothrombin converting to thrombin. So as we look at INR, INR is the international normalized ratio. This is really what patients that are taking those blood thinners are getting tested pretty regularly, usually once a month. INR gives us that gauge of what's normal, what's not normal. Do we need to increase our warfarin or Plavix, or do we need to decrease it, right? And this is 0.9 to 1.3 seconds. It's a standard unit of measurement. That's why it's called the international normalized ratio. Whether you're here or in the UK, if somebody's getting their INR checked, they're going to be using the same value. This is one of the only lab values that you're going to see the same exact thing across the board. It's measured in anticoagulated patients to test that amount of time it takes to form a clot. And as you can see on the right side here, we have a chart with INR numbers. And we said that our normal INR is 0.9 to 1.3 seconds. If you look over on this chart here, 0.9 is going to be down here. It's the normal human range, right? As we move up.
And yet that doesn't say 0.9 to 1.3. It says 0.8 to 1.2.
Right.
Jeez.
I don't get it. Our standard therapeutic target range is what we're talking about with these patients that are taking those blood thinners. It's going to be 2 to 3. That's a little bit wider of a range. But again, we're cautious with patients that are taking blood thinners that have had any recent trauma, such as falls, car accidents, assaults, those types of things, because we know that they're at risk for longer clotting times, correct? Okay. So as we get higher and higher and higher, they can be taking too much Coumadin. They're at a huge bleeding risk. INR will go up if you eat or consume Coumadin, alcohol, or aspirin. And it's going to go down if you eat lots of vitamin K with veggies, avocado, kale, spinach. I don't know what that is, and then green tea. So even in our day-to-day, what we ingest, whether it not be a medication or it is, we can actually adjust how much our time is for clotting. Chronic alcoholics are typically going to have a higher INR time, right? And they're at high risk for stroke. They could be at high risk for internal bleeding. And then as you get lower, these patients are going to have thick blood. They're going to have a stroke risk for clot, and then faster clotting time because they don't have enough Coumadin circulating. Questions about anything so far? Okay. Common anticoagulation drugs, including heparin. Heparin affects the intrinsic pathways. If you have an overdose of heparin, it's going to be protamide sulfate. And then Coumadin affects the extrinsic pathways, or INR. And then overdoses of Coumadin is going to be vitamin K. Let me go back. Sorry. My bad. Everybody online doing okay?
Yes.
Sweet. I know this is a lot. This is kind of it's a big lecture.
Information, that's for sure.
This is, yeah, you're right. It's a super dense lecture.
This is a very nice lecture. I like it.
Thanks.
I'm loving it.
Huh?
I'm loving it. I'm learning something brand new and I'm loving
Yes.
it.
I don't ever expect somebody to memorize every single thing. I don't memorize them. That's why I carry like cheat cards with me and actually have them on here so that if I'm looking at PT, PTT, INR, ALT, AST, ALP, bilirubin, all these, I can just flip to it and look at it, because I might not memorize it, or I might be in the moment and I'm gonna be worked up, right? I'm not gonna be able to remember, oh my God, what is,
That's what I'm
right?
doing. If I already,
So-
I already have some already
It's-
made from what I've already learned.
Super helpful, absolutely. So you don't have to remember the whole thing. That's what I'm kind of getting at. Kyle and I have been stabbing ourselves with forks at times because we're testing each other on these advanced levels. Because we went and took the flight paramedic test, and it is so heavy on lab values.
And it's good to know lab values too, like for all of us to take transfers. I know that it's probably not the funnest thing in the world to take a transfer versus 911, but this is where you can really get into some heavier medicine if you dig into the little packet that they send you with where they've done all the lab values. It paints a much clearer clinical picture of what's going on with the patient. And then you can associate what you're seeing on paper to real people in front of you. That way, next time you see a person that looks sick, you know, in an XYZ kind of way, you can maybe have suspicions or a higher index of suspicion in your head of, hey, maybe this patient is hypocalcemic, or maybe this patient does have a, you know, BUN that's 5,000. Like you can kind of start to put those pieces together. So even you guys that aren't at the critical care level, I would still try to learn this stuff. It'll make you a better provider.
Yeah, absolutely. If you're, say you're taking a renal patient up for dialysis, even though it's a routine transfer, pull their labs out, take a look at them. Because you guys are going to start associating labs with what's going on. And I promise you'll go into the emergency room and you'll drop off a patient and you'll come back and you're like, I think this was this, or I think this was renal failure. I think it was whatever. And so you'll come back and you're like, hey, what was their BUN at? What was their creat? I know Adrian's heard me ask that multiple times. What's their creat? Right. And I want to know what their renal function is so that I can kind of have a better understanding as to where this patient's sitting. Liver function tests. Liver function tests help determine the health of the liver. They measure proteins, liver enzymes, and bilirubin. Again, here's another one of those charts. So they help determine the health through different ways. We have alanine transaminase. Yes, but you're gonna have to help me. I'm ALT.
There you go.
We have ALT. It's an enzyme in the liver that helps the body metabolize protein. It's approximately 7 to 55 units per liter. And then aspartate.
Transaminase.
Thank you. AST is an enzyme in the liver that helps metabolize alanine and amino acid, and it's 8 to 48 units per liter. And then ALP, or alkaline phosphatase, is an enzyme in the liver, bile ducts, and bone. And increase can indicate a blocked bile duct or certain bone diseases, and it's 45 to 115. So each of these tests here, even though they're looking at the liver, ALT, AST, ALP are looking at different aspects of how the liver is functioning, right? ALT is looking at how the body's metabolizing protein. AST is looking at how it's metabolizing aniline and amino acid. And then ALP is looking at the bile ducts and bone. And liver functions include removing potentially toxic byproducts of certain medications. That's why we definitely harp and talk about not taking too many medications for a prolonged time. Common one is going to be Tylenol, right? You definitely want to use the recommended dose of Tylenol. You don't want to take it for 80 days in a row every 4 hours because you're not going to be doing very well. It prevents shortages of nutrients by storing vitamins, minerals, and sugar. So not only does it metabolize different products, but it also stores vitamins, minerals, and sugar. It metabolizes or breaks down nutrients from food to produce energy when needed. So when we eat something, all those nutrients are going to be going to the liver. Produces most proteins needed by the body. So most of the proteins that we're talking about in this lecture. And it helps your body fight infection by removing bacteria from the blood. What else does that?
Ask question again.
Helps your body fight infection by removing bacteria from the blood.
Can you do that?
So you can have some white blood cells too. And white blood cells are made from what?
Leukocytes.
Okay, from what area of the
Oh,
body?
bone marrow?
Bone marrow, okay. And it produces most of the substances that regulate blood clotting. And then it produces bile, a common compound needed to digest fat and absorb vitamins. Need me to go back?
Nope.
Okay.
Good.
Albumin is one of these liver tests. Albumin is a protein made in the liver. Decreased levels can indicate liver damage or disease. It's 3.5 to 5. What was also 3.5 to 5 earlier? What was the other lab that we talked about that was 3.5 to 5? Dude, it's like either really hot or really cold in there.
Either really hot or really cold.
In here, usually.
Um,
That thermostat
Yeah,
doesn't
when
work
it's
for
hot.
me.
I thought you were saying like currently, you're like, I can't tell if it's really hot or really cold in here.
No, it's
That's a
usually
hot
like
flash.
really hot or really cold. 3.5 to 5. Potassium, we talked about that one a little bit earlier. So potassium, albumin, and bilirubin are all going to be the same numbers, but looking at different things. 3.5 to 5. Bilirubin is a protein made in the liver. Decreased levels can indicate, again, liver damage or disease. This is a bilirubin metabolism that I am not going to get into in this lecture.
How is that why we put them under the lights?
Yes. So some other just general laboratory values that we're going to take a look at: lactate, amylase, urine output, and osmolarity. These ones are also really important, especially when we're talking about burn patients. We're going to be talking about renal patients, and any patient that might have a Foley, one that's intubated for a long time. So lactate is 0.5 to 1, and it measures anaerobic metabolism. Elevated levels of lactate are most common from decrease in blood flow to the cells, and it can be from high intensity workouts. Okay, so our body produces lactate as we work out. It increases more and more, and is taken out of our muscles. Amylase is 25 to 125, and it's produced in the pancreas and salivatory glands. It breaks down carbs and food into simple sugars, and it's used to detect pancreatitis. Greater than 300 units per liter within 2 to 12 hours of symptoms. And I think this next one is amylase and do you see what I did?
Yeah, you typed amylase twice. I think you were trying to say lipase for
Yeah.
amylase.
So lipase is 0, you're right. Lipase is 0 to 60. It's produced in the pancreas, breaks down those fats, and then is also used to detect pancreatitis. Urine output is one of the more common ones that we take a look at, especially in burn patients, renal patients. I really enjoy asking about it because I like to see how much they're peeing, because it's going to tell me, do I need to increase my fluid, decrease my fluid? Are they at a good rate? So infants is 2 milliliters per kilo per hour. Child is 1 milliliter per kilo per hour. And an adult is 0.5 milliliters per kilo per hour. On average, that's 30 to 50 milliliters per hour. Okay, so if we have a decrease in urine output, what do we need to do?
Increase.
Increase fluid. If we have increased urine output, decrease fluid. So whenever we start Foley's in the hospital, you're going to get your initial 200-300 milliliters. After that, you're going to drain it, drain the bag, and then time it, check it within an hour. Where are we at? Okay. We really want to take a look at this, especially with electrical burns, any type of burns, hemolytic reactions, rhabdomyolysis. myolysis. And with those ones, especially electrical burns, hemolytic reactions and rhabdo, we want to see urine output at 100 milliliters an hour. We want to flush all those toxins out. So we're actually going to give more fluid than what we would normally see. Normal urine output is going to be that 0.5, 1, and 2. But especially with burns, we need to see a really big increase because we can't see what's going on inside the cells, right? Oh, I missed one. And then osmolarity. Osmolarity is 275 to 295. It measures the weight of a solution and hydration status. We want to titrate hyperosmolar infusions such as mannitol or hypertonic saline, those ones that we talked about earlier. And it increases with dehydration, decreases with overhydration. Oh, that was really hard. Questions? Are you ready for some ABGs? Okay. So ABGs are arterial blood gases. These are commonly used with intubated patients or trauma patients. We're definitely going to take a look at their respiratory values and how their body's metabolism is functioning. We're taking a look at pH, CO2, HCO3, PaO2, and SaO2. So we're looking at each of these things together. They work in conjunction, and we'll learn about that here in a sec. I want you guys to either write these down or memorize these numbers on the right, because I'm going to ask you some questions here in a little bit. The normal pH scale is going to be, they say 7.4 is perfectly normal. However, our pH in our body is 7.35 to 7.45. And again, it's a very narrow range. Our PaCO2 is going to be 35 to 45. And then our HCO3, or bicarb, is going to be 22 to 26. What did I say earlier was also 22 to 26? Venous CO2. Yep, absolutely. So venous CO2 is kind of looking at the same parameters as this one here, but instead of being venous, this one's arterial. They have the 35 and 45 backwards, right? Do you guys see that? Okay, so 7.35 is on the lower end, right? And that is leaning towards acidosis. If you have an increase in PaCO2, you're going to be on the acidosis. And then if you have a decrease in your bicarb, you're going to be on the acidosis side. Okay. So again, following pH, if you have an increased pH, you're going to see alkalosis. Decrease in PaCO2, you're going to see alkalosis. And increase in bicarb, you're going to see alkalosis. Does everyone kind of understand that? Okay. So pH is the potential of hydrogen. It's used to specify the acidity or the basicity of a solution in the blood. We use pH. pH can be used for any number of things. It can be used for your tap water at home. It can be used for your water bottle that you're buying from the store. Milk, literally anything, we're looking at pH. Is pH in 0.9% sodium chloride acidotic or alkalotic? In 0.9% sodium chloride, so normal saline, is it alkalotic or acidotic?
Acid.
Acidotic, so it's lower.
Yeah.
Yeah, so normally in saline, we are seeing like 7 to 7.2% pH, not percent pH. pH is 7 to 7.2. So automatically, we're starting to give them acidotic saline, if we're just filling them with 2-3 liters. What's a solution that EMS does carry, we don't carry it here, that has a normal pH? More normal pH,
Activity ringers.
lactated ringers. Yep. Partial pressure of carbon dioxide, or your PCO2, measures the amount of carbon dioxide in the arterial blood, just like our venous arterial carbon dioxide was measuring venous earlier. This is actually measuring in the arteries. It's a marker for alveolar ventilation within the lungs. So it's telling us, again, respiration, and how much we're actually blowing off. Can we measure this? How?
Capno.
Capno. Yeah, so we use end tidal all the time, right? This is kind of the standard of care that we're using, especially whenever we're talking about any type of progressed respiratory patients. So CO2 exists in the blood as a soluble gas, and it's a byproduct of metabolism. It's an indicator of acid, and CO2 regulation is a function of minute volume. So we can actually regulate somebody's CO2. Minute volume is tidal volume. What's tidal volume?
The total capacity of your lungs.
No. You're on the right path, but no. It's the amount of air or oxygen that you need for respiration, which is less than your total.
Oh, okay.
Think of it like the average amount of air that you move in and out of the lungs with each breath. So if you just take a normal breath in and a normal breath out, that's your tidal volume. But if you take a normal breath in, you know, you can keep sucking in more.
Oh, yeah.
Yeah, that's not part of your tidal volume. If
Gotcha.
you take a normal breath out and you can push out more, that's not part of your tidal volume.
Okay.
How many milliliters is a normal tidal volume?
6 to 8.
6 to 8 milliliters per kilo of
Maybe about-
ideal body weight. So minute volume again, tidal volume times respiratory rate. That's how you can calculate minute volume. Tidal volume times respiratory rate. If I'm giving on average 800, 900 milliliters, we'll just round to 1,000 milliliters, and my respiratory rate is 12. What's going to be my minute volume? You're a paramedic. 1,000 times 12.
12,000.
12,000. Surprised you got that.
Good job.
Listen,
He's calling you dumb.
Listen, the gerbils are barely running.
So partial pressure of carbon dioxide. This one's important. We can measure this in the field. Bicarb or HCO3. Bicarbonate measures metabolic function, and blood brings bicarbonate to the lungs, which is then exhaled as CO2. The kidneys also help to regulate this through urine secretion, and then it moves in the same direction as your pH. So if your pH goes up, your bicarb goes up. If your pH goes down, your bicarb is going to go down, and your carbon dioxide is going to move opposite. Okay. PO2 is your partial pressure of oxygen. This is different than your SaO2. Your SaO2 is what we can measure, right? We can put a pulse ox on somebody's finger and say that they're 98%. In the hospital, they're measuring PO2, which is your partial pressure of oxygen, and it's the amount that's dissolved in the blood. So you have your PO2 levels and your SaO2 levels. If somebody's at 100% oxygen on our pulse ox, their PO2 levels should be 90. As it drops, once you get to 90, it's 60. 60 is 30. 50 is 27. I don't know. That doesn't make any sense to me, but yeah.
I learned it the 4, 5, 6, 7, 8, 9.
Yeah.
Yeah.
So SaO2 is our saturation of the hemoglobin, and then partial pressure is that dissolved oxygen within the blood. So remember, 100 is 90, 90 is 60. Do you want to teach them your?
Sure. So the way that I learned this, because yeah, this chart's weird. I don't know what the 27 millimeters of mercury is write down 4, 5, 6, and then 7, 8, 9 in like a separate little column. And so the 4 is 40. If you have a PO2 of 40 millimeters of mercury, you should have a SaO2 of roughly 70%. If you have a PaO2 of 50, then you should have an SaO2 of roughly 80%, and so on and so forth. So by the time you get to PO2 of 70, that should roughly equal SaO2 of 90,
Perfect.
or no, 60.
Yes. I am not going into this
I would love to talk about this.
tonight.
If somebody wants to.
Yeah.
Do you want to? Okay. So I'm gonna let Kyle take this. This is the oxyhemoglobin dissociation curve. This is like pretty advanced level of thinking, but I'll let you talk about it.
Sure.
Okay.
Yeah. So this is the, how's it going, guys? This is one of the principles that causes paramedic students and critical care students to like have nightmares and, you know, freak out because it's kind of a hard thing to follow. But I personally don't think it needs to be that complicated. I think you can sum it up pretty easily. So if you're looking at the right side and the left side, each one respectively represents whether you're in acidosis or alkalosis, as we can see. So if you're in a left shift, you're going to be alkalotic. If you're in a right shift, you're going to be acidotic. Now this middle curve where it says normal is where we live normally. And basically what this chart represents is how easy it is to get oxygen onto the hemoglobin and then how easy it is to get oxygen off of the hemoglobin. So if you see, looking at the bottom of the chart here, I don't know if you guys can see me or not, but I'm pointing down here, like at the, oh, okay, well, at the base of the graph, you see how it kind of starts and then has a pretty dramatic upslope, and then it kind of gently tapers off and curves more, you know, at a plateau. What that's representing is a sharp uptake in the amount of hemoglobin that we're initially loading with oxygen. As that steadily climbs up, eventually it starts to taper off and we're no longer having that dramatic rate of hemoglobin saturation. It's kind of a cool principle that dictates this. You have this principle called cooperativity with our hemoglobin that basically states that hemoglobin on its own is a really jagged, messed up looking protein that is not really conducive to holding oxygen. So an empty heme group on a hemoglobin doesn't really want to accept an oxygen molecule. But if you can pack enough oxygen into the plasma in the PaO2, eventually one of those heme groups, one of those hemoglobin is going to pick up an oxygen molecule, and it changes the structure of the protein to where then the heme group next to it, because in a hemoglobin you can take 4 oxygen molecules per hemoglobin, it'll change the protein structure of the one next to it, making it much more readily acceptable of an oxygen molecule. And then when that one gets an oxygen molecule, the one next to it, it's even easier for it to take up an oxygen molecule. And again, as you're filling up these heme groups with oxygen, it becomes easier for the next one to get oxygen. Does that make sense? So if you're looking at the curve, you can see why that ends up being a pretty dramatic upslope after we first get that initial saturation down at the bottom. And then once we get to the top of that curve, we've already packed everything full of oxygen that we can. So there's really not a whole lot more, and that's why it tapers off. That's the quick and easy way, I guess, to try to figure out what the normal represents. Now, what the left shift and the right shift are talking about are different situations that impact either how easy it is for the hemoglobin to accept oxygen in the first place, or how hard it is for it to drop it off at the tissue, okay? So down here at the base of the graph, if you're looking down here at the bottom left, that's at the cellular level where we're trying to pick up oxygen onto the hemoglobin. And then up here at the top of the graph is us dropping it off at the tissues. So in a left shift, you're going to be alkalotic. With an alkalosis, you're typically going to have an environment that is low in CO2. You're going to be low temp, and you're going to have, this isn't showing the 2,3-DPG, it should. There's a protein called, I can't remember off the top of my head, but it's called 2,3-DPG, and it's basically the crowbar that wrenches oxygen off the heme groups. That's going to be high in a left shift. And so on the right side, you're going to have a acidosis, you're going to have an increase in CO2, an increase in temp, and then the increase in hydrogen is obviously the acidosis, and you're going to have a low 2,3-DPG or a high 2,3-DPG. The point here, what you're trying to think about is that think of left shift as not only alkalosis, but what's going on in the lungs. Think of right shift as not only an acidosis, but what's going on in the tissues. So in the lungs, we have a low amount of, how am I trying to explain this? Let's go with low temp. Let's start with that. A low temp in the lungs, right? Because we're breathing cool air. So that makes it easier for oxygen to load onto the hemoglobin at the lung level. And then as we get to the right side of the curve where we're in the muscle tissues, that's where muscle is being used and actively moving. That generates heat. So that's going to be an increase in temp. So it makes it easier to offload the oxygen at the tissues. Same thing with, I don't know why it's talking about the CO2 here. It's basically coming down to the total amount of acidosis and temperature and what it does to 2,3 TBG that determines your left to right shift. I wish I had better visual aids for this for you guys. Sorry, it's hard to talk through it with it out of being on the screen. But think of it basically as what is impacting the oxygen carrying capacity of the blood. If it's going to be easier for it to onload and harder for it to offload, or is it going to be harder to onload and easier to offload? Did I say that right? I didn't say the same thing twice, correct? Okay, cool. I just want to make sure. That's basically what this is talking about. It's a pretty important thing. You don't need to be an expert in it up front, but if you can grasp this concept, then you can tie this back to your patient in like real time, and you can track outcomes for your patients on what's going on with their base balance. So anyways, I'll turn back over to Trev.
Thank you.
There's a
Kyle.
reason why I didn't want to go deep into it, because you can get definitely into a rabbit hole and then start talking about different disease processes and how the respiratory system is working with the rest of your body. So this also could be another lecture. Again, this lecture that I'm giving tonight is an encompassing lecture that is talking about the grand scheme of things and how our body is working with all these different electrolytes and proteins and everything. So when we interpret EKGs, wrong lecture, ABGs, when we interpret ABGs, these are the different names and phrases that we're going to be using tonight. Okay, so we're going to be using respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, partially compensated respiratory acidosis and alkalosis, partially compensated metabolic acidosis and alkalosis, and then fully compensated in all four. Okay, so we're going to understand if somebody can be in respiratory acidosis, but they can be compensating, right? How might they be compensating normally for a respiratory problem? Respiratory acidosis.
Breathing. Rapid, deep.
Okay.
Respiratory acidosis?
It would be respiratory acidosis.
But the picture is yes.
Compensating.
Yeah,
By breathing too small.
Your body is trying to compensate.
Yeah.
Your body's going to try to compensate. So these are the three questions that I want you to ask yourself as we go through these. Which way does the pH travel? Is it acidic or is it basic? Is it respiratory or metabolic? In other terms, does the PaCO2 or the bicarb follow the same direction as the pH? Okay, so again, your bicarb, is it going in the same direction? And is the ABG compensated or uncompensated? And we'll work through these together. Okay. This is Adrian right now.
I love how you have it.
Let's be on every lecture.
So, bro.
Am I the only one that likes lectures? Obviously.
This is a great.
These guys do. So,
I love that. Yeah.
start with the pH. Which way does it travel? Okay, when we look at the pH, our normal is what?
3.4 give or take.
Or technically,
Or 7.4.
well, it's 7.35 to 7.4.
Yes, not that.
7.4 give or take.
It's all right.
7.35 to 7.45. Okay, so again, here's that chart just like earlier. We have our acid and our bases. Our acidic side, our pH is going to be low, and our bicarb is also going to be low. Okay, our alkalines, pH is going to be high, bicarb is going to be high. So does the CO2 and bicarb follow the pH? And when we look at this, we want to take a look, if we're talking respiratory, so respiratory acidosis or alkalosis, we're taking a look at what two figures?
For
Initially.
respiratory?
Yeah.
pH and your PaCO2.
Correct. And your metabolic processes
That's gonna be your HCO3
and
and your pH.
perfect. So if we're trying to figure out, is this respiratory or metabolic? That's one of our first questions, right? We want to correlate two of the numbers together. So if we have a high pH, we need to be looking at both our PaCO2 and our bicarb to see which one is also high or low, which one correlates with your pH. Does that make sense?
Yes.
Everyone got that so far? Okay. So which value follows the pH, and does the other value travel in the opposite direction to become compensated? What do I mean by that? So if I have a high pH, my pH is 7.5, and my bicarb is 30, I need to be looking at my PaCO2, right?
Yes.
If it's also high,
Uncompensated.
uncompensated, why?
Because it's all going along with alkalosis versus if it's a metabolic alkalosis, you should be having respiratory acidosis.
Okay, you're not wrong. So if my pH is high, 7.5, my bicarb is 30, but my PaCO2 is the same, I have metabolic, right? Because bicarb is metabolic. And my pH is high, my bicarb's high, so this is going to be metabolic what?
Alkalosis.
Alkalosis, because they're both high, right?
Yeah.
Okay, if it was partially compensated, I would see my PaCO2 to be low, correct? Because it's trying to compensate in the opposite, or, excuse me, my PaCO2 would also be high because it's trying to compensate. Does that make sense?
Wait, can you say that again?
So my pH is high,
Yes.
my bicarb is high.
Yes.
I've determined this is metabolic alkalosis,
Yes.
correct? So if I then have a PaCO2 of 48, which is going in the acidosis side,
Yeah.
right? It's trying to compensate. Does that make sense?
So when does it become fully compensated?
Good
versus
question.
partial?
When is it fully compensated?
All.
Not all.
Your pH is back in balance?
Yes. So if you might have a pH of 7.42, but you have a bicarb of 30 still and a PaCO2 of 48. Those are way out of whack, right? Both those are completely out of whack, but your pH is in normal balance.
So that would be partially compensated.
Partial.
Fully compensated.
So you're going to be fully compensated because your pH is back, but your pH is now leaning towards alkalosis still. So I can tell that this is a fully compensated metabolic alkalosis. If it's partially compensated, I'm starting to get that shift, but not completely. Everybody follow? Okay. It's not, is it as hard as what you guys were thinking?
I
really
remember
good-
this from your last lecture.
A really good way to do it is
Like
to
2 years
draw-
ago?
Yeah, put X's, like if you write it exactly the way that he has it on the board for the pH, the PaCO2 and the bicarb, and then write an X either on the acidic side of the pH or the alkaline side of the pH, and then same thing for the PaCO2 and the bicarb. Just put X's where they are, and then it's really easy to visualize it and see where things lie.
So this one gave it to you.
Oh, yeah.
Oh, yeah. So we're gonna still work through this one a little bit. Your pH is I'm gonna, hold on.
There's all the answer, guys. Take a picture.
Wasn't paying attention. Put it back up.
No, changed it.
Even that, we can run different scenarios.
How do I, because it's like blurring the background.
I have ABG, what are you asking?
Anyone? It's like blurring. Oh, there it is. Okay. Let's see if that worked. Oh, it did. Okay. Okay, so our pH is 7.3. Our PaCO2 is 46. And our bicarb is 25. So let's work through it. Is our pH acidotic or alkalotic?
Acidotic.
Acidotic. Okay, and our PaCO2? Acidotic. And our bicarb?
Normal.
Normal, right? It's in between 22 to 26. So this is metabolic, or sorry, yeah, respiratory or metabolic?
Respiratory.
Because
Because your PaCO2 is 46, which is leaning more towards acidotic, versus your HCO3 is within normal limits.
and your pH is off still,
Yes.
right? So this is
Respiratory, acidotic, uncompensated.
uncompensated respiratory acidosis.
Tomatoes, tomatoes.
Does that make sense? Okay, so you're right. Uncompensated respiratory acidosis. pH is 7.3, PaCO2 is 46, and our bicarb is 28. So pH, acid or base?
Acid.
Acid,
Acid. Your PaCO2,
acid,
acid, and your bicarb.
alkalotic.
Okay, so we have, is it compensated or uncompensated? Is your pH normal?
No.
Partially compensated.
Uncompensated.
Yeah, it's partially because your pH isn't in balance, but your bicarb is trying to compensate for it.
Correct. So in full, this would be,
Partially compensated respiratory acidosis.
perfect. All right, next one. pH is 8.4. Your PaCO2 is 43. And your bicarb is 27. pH is alkalytic. Your PaCO2,
Normal.
normal. And your bicarb,
Alkalotic.
alkalotic.
Yeah.
Okay, so we have bicarb that's leaning towards alkalosis, and we have our pH, which is also leaning towards alkalosis, right?
Yes.
So is this metabolic or metabolic or respiratory?
Metabolic.
Metabolic. And is it respiratory or alkalosis? Is it acidosis or alkalosis?
Alkalosis.
Alkalosis. So we have metabolic alkalosis. Is it compensated or uncompensated?
Uncompensated.
Uncompensated. So in full, this is
Uncompensated metabolic alkalosis.
uncompensated metabolic alkalosis.
Yeah, I can say words.
Next one. pH is 8.4. PaCO2 is 47. And our bicarb is 27. Our pH is, yes,
I was gonna say the answer. Can I skip to the answer?
let's work through it as a group so we can get the practice. 8.4 is
Alkalotic.
alkalotic. Our PaCO2
Acidotic.
acidosis and our bicarb
Alkalotic.
alkalotic. So our pH and our bicarb are traveling in the same direction. Our PaCO2 is traveling opposite direction. So this is it's not fully compensated.
Compensated metabolic alkalosis.
Partially compensated metabolic alkalosis. You have a paramedic on your hands.
This one? I know. I'm a lucky guy.
pH is 8.6, PaCO2 is 33, and bicarb is 23. pH is
Alkalotic.
alkalotic, PaCO2
Alkalotic.
alkalotic. So this is a
Respiratory alkalotic.
respiratory alkalosis,
Yes.
and our bicarb is 23. Normal range. Is it compensated or uncompensated? Uncompensated. So this is
Uncompensated respiratory alkalosis.
alkalosis. Perfect. Our pH is 8.6. PaCO2 is 33, and bicarb is going to be 20. Yes.
Can anybody live with an 8.6 pH?
Good answer, or good question.
Yeah, not for very long though.
Okay.
pH 8.6. PS alkalotic. PaCO2 alkalotic. Bicarb acidotic. Is pH in normal?
No.
Uncompensated or compensated?
Partially.
Partially compensated respiratory alkalosis. Last two. pH is 6.9. PaCO2 is 37. And your bicarb is 21. pH is
Acidotic,
acidotic. Your PaCO2
alkalotic,
alkalotic, and your bicarb
acidotic.
acidotic. So pH is not normal. This, what travels with your pH in the same direction?
HCO2, HCO3,
So your bicarb is traveling in the same direction in the acidotic side. So this is metabolic or respiratory?
metabolic,
Metabolic. So this is fully, partial, or uncompensated.
partially.
Uncompensated.
I'm going partial.
I'm going uncompensated.
Why? Why and why?
Justin?
I'm going with Y because your PaCO2 is in the alkalotic side. It's trying to compensate, but it can't quite. If it was uncompensated, it'd be within normal limits.
So the PaCO2 is within normal range, making it uncompensated because it's not going in the opposite direction.
So this is
Correct.
uncompensated metabolic acidosis.
Yeah.
pH is 6.9. PaCO2 is 33. And your bicarb is 21. pH is acid or base?
Acid,
Acid, PaCO2, acid or base?
base,
Base, and bicarb,
acid,
acid. So what travels with your pH? Bicarb to the acidic side, right? So this is a metabolic or respiratory?
metabolic,
Metabolic. And is it compensated or uncompensated?
partially compensated.
Partially compensated. So in full, it is
Partially compensated metabolic acidosis.
partially compensated metabolic acidosis. Awesome. Was it as hard as you thought?
Trying to say all those words in one sentence? Yes.
Partially.
Wording is hard.
Yes.
Yeah, I know.
Numbers are easy.
We got more?
There's a few more here. So your pH is 7.3, your PaCO2 is 46, and your bicarb is 28. Is your pH normal?
No.
Jerry, I would like to
What is it?
answer the question. in full.
Go ahead. Benji.
Respiratory or partially compensated respiratory acidosis.
Partially compensated respiratory acidosis. Perfect. Your pH is now 7.38. Is that normal?
Yes.
And your PaCO2?
No.
Which way does it lean?
Acetone.
Acidotic. And your bicarb? Alkalotic. So how do we figure out what it is?
Which one's worse?
Nope. Which way on the scale does my pH lean? More towards alkalosis or acidosis?
Oh, I see.
Acidosis. And which other one leans towards acidosis?
PaCO2.
PaCO2. So this is
So is this compensated respiratory acidosis?
fully compensated respiratory acidosis. So what you're going to be taking a look at is your pH, right?
Yeah.
7.35 to 7.45. But if you have all of these numbers don't, I mean, two of these numbers aren't correct, right?
Right.
And they're not traveling in the same direction because they can't. So you need to take a look at your pH and figure out which side of that sliding scale are they on?
Okay.
More acid or more base?
Gotcha.
And then take your other two and figure out which one travels in the same direction as that.
Okay.
Okay.
Is it possible to have all three of those going in the same direction?
Yes.
All right, and then what is that called?
Mixed gas and balance.
Yeah.
A what?
Mix fasting. Mix. Now you're doing it to me.
Mixed
Mixed
Gas
gas
and
imbalance.
And it's really bad.
So your pH is 8.4, acid or base,
Base alkalosis.
PaCO2, and bicarb.
Base.
So this is
Metabolic,
Partially compensated metabolic alkalosis.
yes.
okay. So next we're taking a look at a pH of 7.42, PaCO2 of 47. And now you have a bicarb of 27. pH normal or not normal?
Not, it's closer to alkalosis.
Normal, but leaning towards alkalosis. PaCO2, acid or base?
Acid.
Acid, and your bicarb. So which one travels with your pH?
Your bicarb.
Your bicarb. So this is going to be a
Compensated metabolic alkalosis.
Yes.
okay, fully compensated metabolic alkalosis. Remember the fully part.
Okay.
pH is 8.6. Your PaCO2 is 33. And your bicarb is now 20. Acid or base? Base, which one travels in the same direction?
CO2.
Your CO2, so this is
Respiratory,
Good.
alkalotic, but. I'm a brain think, let the gerbils get going. This will be.
is your pH normal?
No.
Partially compensated.
Partially compensated respiratory alkalosis. Perfect.
Way to go, Teach.
It's not John.
It wasn't the gerbils either.
Thank you.
Yeah, absolutely. You're doing awesome. pH is 7.43, PaCO2 is 34, and bicarb is 19. Is your pH normal?
Yes, but we-
Yes, but leaning towards
yeah.
alkalotic. So which one's also alkalotic?
CO.
CO2. So this is
Partially compensated respiratory alkalosis.
Is your pH normal?
Mm-mm.
Yes,
Well, it is
fully
compensated.
compensated. 'cause
Fully
it's
compensated.
Fully compensated because it's 7.35 to 7.45, right?
But
So
it's
we're
still
in-
leaning.
It is leaning, but it's in the correct range.
Yeah.
If your pH is in that
So fully.
7.35 to 7.45, that's what makes it fully compensated.
Okay, understood.
Your pH is 6.9,
Hmm.
PaCO2 is 33, you're a child.
Nice.
21. 21. pH, acidic,
Acid-
which one travels in the same direction?
HCO.
Your bicarb, yep. So this is metabolic or respiratory?
Metabolic.
Metabolic.
And is
So
it
partially.
partially compensated? Metabolic acidosis. Last one. pH is 7.36, normal or abnormal?
Acidic.
It's acidic, but in the normal range. PaCO2 is 27, normal
No,
acid or base.
base.
Base, bicarb is 19,
Acid.
acid,
Metabolic.
okay, yes, someone say it.
Fully compensated
compensated
metabolic acidosis.
Acidosis.
Fully compensated metabolic acidosis. Dude, you guys are killing it.
Hell yeah.
Beginning of practice, it was kind of difficult to understand, right? And now you guys are like Johnny on the spot. All right, if you want more practice, you can go to ABG Ninja. It's a website that you can practice ABGs. It's interactive medical education. They have a bunch of different interactions that you can use.
I'm gonna be kicked off. I'll be on
So you can scroll through it. They have medical quizzes, EKG rhythms, arterial blood gases, ST elevated MIs, so that you can, for anybody that's looking for more EKG practice, MIs. They do Glasgow coma scales, APGAR scores, Braden scales. They have anatomy quizzes such as cranial nerves, and then phonetic alphabet, and then 10 codes. So if you click on arterial blood gases, you'll go in here and you'll literally look at all of your pH, PaCO2, your bicarb, and then you can go for your primary problem: metabolic, respiratory, or combined, acidosis or alkalosis, fully or partially compensated, and whether it's compensated or not. So once you start answering it, it's going to tell you what you got right, what you got wrong, and you can do as many of them as you want. It's just going to keep spitting them out.
Hold up, this is a curveball. What is the combined?
That's like that mixed gas.
Oh,
This is what it'll look like after you answer one. So you have primary problem is metabolic acidosis, right? And then level of compensation is partial, and then respiratory acidosis. So it's going to say the pH and bicarb levels are both acidotic. So the primary mechanism is metabolic acidosis. The respiratory alkalosis is compensation for the bicarb, but the pH is not within normal limits. So it's only partially effective.
That's a cool site.
It's pretty cool. Do you guys have any questions? Any questions? I know it was a lot. We went slightly over 2 hours. Here's my references for anybody that wants to take a look at them. No questions? Anybody online?
No.
Okay. Thank you guys very much. I know this was a intense brain lecture. It really makes you think, and kind of a lot of rogue memorization and a lot of practice. But I hope you guys kind of understand the importance of lab values, kind of taking a look at them and how we can use them even in our practice pre-hospital and doing interfacilities. So Kyle has one thing that he wants to ask you guys before we finish up, and then you guys are good to go.
All right, guys. So when we had our company meeting, for those of you, I can't tell who's online or not. One of the things that I asked was for suggestions on what topics you guys would like to have discussed for our CE education. So if you guys have any topics, any specific stuff that you would like to see covered or go over, if you could either shoot me or Travis an email with that topic, that would be great. That way we can start working